I'm very happy to be here. Like David said, aHUS has been a big part of my life and my short still career. It's where I start. I have a lot of passion for what families go through, and it actually inspired me to go back to school after my PhD to become a genetic counselor in hopes that things like the complement system and genetics just in general, it's really complicated, and how do we help patients and their families understand this information in a way that's helpful so that they can be advocates for themselves and understand it so they can make decisions for their family members. And so I hope today my talk gives you some more of that information. If any of you were in Denver when I gave this talk, it's very similar to that talk, so I apologize in advance. We haven't learned too many new things about the genetics of aHUS since then, but please, I'm looking forward to all of your questions at the end. So my goals for today are to get a basic understanding of genetic concepts. So some of you probably have had genetics in school, so this might be a little review. Some of you may not have had genetics in school, and so it might be a little bit new. But all of this is important to understand where we go later in the talk when I'm talking about things that are a little bit more complex. Then we're going to do an overview of the genetic cause of aHUS, and I'm sure everyone in this room is aware of the genes that we know of that when they have mutations in them can predispose people to developing symptoms. But I'm just going to go over it in a little bit more detail and put it into context about what we know about those genes and what that means for someone who tests positive for that mutation. Then we're going to talk about how aHUS is passed down in families. I know I see a lot of young people in this audience that this is something that's really important to people when we talk about genetics. So it's not just what does this mean for me and potentially my treatment moving forward, but it's natural for us all to think, what does this mean for future generations of my family and how is this passed down? And then finally, I'm going to attempt to answer some of your most common questions without you having to ask me them. These are just common questions that whenever we talk about genetic testing, it's not specific to aHUS, just genetic testing in general, people often have these questions. So just a little bit about my background, and this was already introduced, so I'll be quick. So I started my career in Richard Smith's lab working on discovering other potential genetic causes of aHUS besides the genes that we had already known about that were part of the complement cascade. And then I went back to school to become a genetic counselor because what I realized when I was doing my PhD is that there's a lot of good information that's being found in laboratories all across the country, but it's not always making it to the people that it can help the most in a way that's helpful. And so what a genetic counselor's job is, I consider this my only job, is to break down complicated things in a way that it's simple enough that people can make educated decisions about their health care and their future family planning, okay? It's not to make judgments, it's not to tell people what to do, it's to get them the information so they can understand it. And right now I'm actually working in a genetic counseling clinic that I talked with women who are at high risk with breast cancer or other cancers in their family about if there could be a genetic cause to that, and if there is, how can we prevent future generations from going through what that generation went through in terms of cancer risks. All right, so this is definitely very broad, but what is a gene? What does it do, and how does it make it when you have a mutation in a gene that leads downstream to having symptoms of something? And what we know is, in every cell in your body, you have DNA. And that DNA has about 20,000 genes in it. And that's just what we know. There's probably other things in your DNA that are important. I remember when I was an undergrad, they said 99% of the genome is junk. We know that's not true now, and in the past 15 years, we've definitely proven that as a falsehood. And your DNA is wrapped up into your chromosomes, and this is the unit that's passed on to children. So your DNA is passed on through your chromosomes, and then within your chromosomes, you have genes, and then these genes get made into proteins, and the protein is the actual thing that does the job in your body, okay? And I know that's pretty general, and most of you probably already knew that. And what is a mutation? We all have mutations. I always tell people I talk with, each one of us probably has a couple thousand mutations in our DNA if we went looking for them. Most of those mutations don't do anything. Some of those mutations are good and make us healthier, and some of those mutations cause us to have health problems. And it's a naturally occurring process. It happens over time. And how I like to think of a mutation is it's a spelling error in your DNA. In some cases, these spelling errors change the meaning of the code, and that can affect how your body works. So it changes how that protein is made, and so that protein then can't do its job like it should be in your body. And then, and depending on what that protein does, that can make us sick. Now, this is just an example, so cat, and then if you switch that A out to an H, that's a spelling error in your DNA, and now that has a different meaning, and if that was in a sentence, it wouldn't really make sense, right? So that's my very general intro to genetics, I promise. So what are the most common types of mutations that we see in patients who have aHUS? The most common are a point mutation, and what this means, if a doctor's ever saying this to you or you're reading it online when you're doing your research, is it means there's a single letter change. That's all it means. It's a point mutation. In one point, there's a change. And so an example of that is that one we already talked about, that cat to hat. Just the H changed, but it was enough to change the meaning of what we're talking about. Another common mutation that we can find in families with aHUS is a deletion, and this is really self-explanatory. It just means something that should be there is no longer there. Somehow it got deleted when your DNA was fixing itself, okay? And these deletions can be a single letter, so if we get rid of that A and now it's a CT, doesn't make sense anymore. But these deletions can also be full genes, so full genes can be missing. And that can cause people to be predisposed to aHUS. And we'll talk about what those deletions are very briefly. And lastly, duplications. So the same idea, it's pretty self-explanatory. Something that's there once is now there twice or 3 times or 4 times, okay? And because of how your DNA works, what happens is it gets read in a sentence, and so if something's deleted, it can mess up the message and make it so that protein doesn't work right, or maybe you have too much of a protein and you should have less of it, okay? And so that's what the duplication is. And just in general, when you're looking at test reports, point mutations are a little bit harder to say for sure that that's causing something to go to change or not work. But if you have deletions and duplications, it's very safe to say that that is changing the function of that gene or protein enough to make something not work. Okay, so they're just a little bit more what we know in science when we talk about those. If we see that, we're a little bit more confident that's it. That's probably related to something that we're studying. Versus point mutations, which I said earlier, we all have lots of point mutations and most of them do nothing. And so it's just a little less obvious sometimes if that's the thing that's causing what we're looking at. So finally getting to something that is directly benefiting or has to do with aHUS. So we know there are quite a few genes that if we find a mutation or spelling error in them, it can predispose someone to developing symptoms of aHUS. The most common mutation that we find are mutations in factor H. About 30% of patients who are tested will test positive for some mutation in that gene. Second most common, and these are all estimates, so different studies at different times, that's why there's a range and it's not exact. We could say for CD46 or the membrane cofactor protein, about 12% of patients will test positive for mutation in that gene. C3 is more rare, factor H is more rare, 5 to 10%. Factor B is probably one of the the rarest. There aren't that many cases of mutations in this gene. It makes it hard to study. It makes it hard to understand what mutations in those genes mean for people. Even though we expect that they likely do predispose to symptoms, it's harder for us to know exactly what that looks like because there's just fewer people to study. And then the newer genes that were found is THBD, and The newest gene is DGKE. This gene is different, and I'm going to talk about this kind of separately from other genes that we talk about today, because this gene is inherited in a different way than every other gene on this list, and it primarily explains symptoms of aHUS manifesting before the age of 1. Okay, so a little bit different than what we traditionally think of when we think of patients with symptoms. And then, of course, we know deletions of the factor H-related genes, and I should add factor H-related 4 in there because I was just, before I came here, looking up the newest research, and I know that there have been some deletions of that gene that have also been included, which makes sense. We know that these genes function a lot like factor H. They're very similar, and so it would make sense that if those weren't working, we might predispose someone to the same symptoms. You can also have duplications of these genes as well. So I don't need to tell anybody in this room that this is a complex disease. I'm sure people have been telling you that since you've heard about this disease. We know that it's usually not a single mutation that leads to symptoms. It's more complicated than that. It's likely some genetic. We know that there are environmental triggers, and it might be a combination of more than one genetic thing. And so for the genetic component, we just talked about the genes that we know are involved. You can have mutations in one gene. There are rare cases where people have testing. Now it's common to do panel testing where you don't start with the most common gene and then if it's negative, go to the next gene. You can do testing for all of the genes that we know are available at the same time. And what that has led us to discover is that people can have mutations in more than one of these genes. And then most of these genes are related to the alternative pathway of the complement cascade. And then, of course, the environmental factor, infection by bacteria or viruses, drugs, pregnancy, and other things. So here's my very simplistic drawing of the complement cascade. And so we're just going to concentrate on the alternative pathway. This is where most of the genes that we know of that can, if they have a mutation in them, lead to symptoms are. And the complement cascade, you can see here's factor B, MCP, factor H, factor I, C3. And I have to thank Richard Smith for these slides. He made them actually for my thesis defense, and I just keep using them. So this is the complement cascade on the surface of a bacterial cell. So the whole reason we have the complement cascade is it protects us. It's a good thing. It protects us against getting bacterial infections. And on our own cells, which is just another way of saying host cells, so our own body cells, what should happen is that when the complement cascade starts going, our body says, nope, that's not a bacterial cell, you need to stop, right? And we know in patients who have aHUS, this is where this doesn't happen, so it doesn't get stopped. And because it doesn't get stopped, it starts attacking your own cells in your body, and that's where we get these symptoms that lead to aHUS. And this makes sense when we think about some of the genes that are involved in aHUS. A lot of the genes we find mutations in are regulators of this complement cascade, right? So it's their job to stop this. So if you have a mutation in that gene and it can't stop it, that's where we see symptoms. This is a really common question that I used to get when I was doing my work in the Smith lab. So, is one gene worse than the other gene to have, right? So if you're going to get genetic tests, you're likely going to get tested for everything. Is there something I should be hoping that I test positive for versus a different gene? And how we know this is because there have been studies to look to see if there are patterns. And how that works is they take, and I know this is a very rare disease that we're talking about, but they take as big of numbers as they can, and they say, okay, if everyone with a mutation in gene A has a more severe outcome, and everybody with a mutation in gene B has a less severe outcome, then that's good evidence that suggests there's a difference, right? But it's important to know that since this is how the studies are done, and they're relatively small studies compared to other genetic studies because of just how few people have this diagnosis. These are generalizations, and it doesn't mean for sure that everybody is going to look like what that study said, right? Everybody's different. This is a complex thing that we're talking about. Everybody is going to have different environmental things and genetic predisposition. And then, because these genes and their proteins are made in different parts of the body and have different jobs in your body, when I was studying, it was pretty important to know what gene you had a mutation in, because it helped doctors know how you would respond to treatment. And this is still going on. I just read a paper that was published in the past year suggesting now they're taking this information and they're trying to figure out if you have a mutation in factor H or factor I, does that change how you respond to Soliris? And does that change if you need to stay on Soliris, or can you go off of Soliris? And so these are the kind of studies that we're trying to help personalize medical management for patients based on their genetic test result. I am not an MD, and so I will not give advice on this, I promise. But this is something that you could bring up with your doctors and just say, do you know about this? Or if they bring it up, at least you were introduced to the idea. And so what we know in the latest information is that factor H, and I'm not going to go through this whole thing, I'll just talk about 3 of them. And then this, I said it was okay to share my slides. I don't know if you already have these slides with you, but this is for your benefit when you're at home and you want to read through this. So for factor H, for example, 70% we think present in childhood, and they have a pretty high rate of relapse, patients who have mutations in this gene. And if we can compare that to CD46, most present in childhood, and some in adulthood, and in general there seems to be a milder phenotype in those patients where we only find a mutation in that gene. And then of course the really different gene is this DGK gene, where we know 100% of patients who have this genetic predisposition factor will present before the age of 1. All right, so how does this pass down in my family? If I know I have a mutation in one of these genes, what does that mean for my future children or my current children that are here? Most types of aHUS are passed down in a way that's called autosomal dominant. And what that means is you can get it from your mom or your dad, and all it takes is 1 copy to have a mutation in it. So we all have 2 copies of most of the genes in our body. Men are, they only have 1 X, so that's like the difference. But for most genes, we have 2 copies. And so 2 copies. And most people have 2 working copies of all of these genes. And we know in aHUS, when we test people, some people test positive for a mutation in factor H, for example. And having 1 copy that doesn't work, it can't do its job, is enough to put someone at higher risk of developing symptoms. It's not enough to say for sure they'll ever develop symptoms, but it's predisposing to symptoms. And so because of that, because you have 2 copies and we don't pick what we pass on to our children, that means that anytime you have a child, there's a 50% chance you could pass on the copy that has that spelling error mutation, and a 50% chance that you, even though you tested positive, would pass on the copy that doesn't. Okay? And then that child would grow up and isn't at higher risk, right? So what we say for aHUS is that this is a genetic syndrome, and you might have heard these words before on websites, that's autosomal dominant with incomplete penetrance. So what does that mean? It means autosomal, it can be inherited from mom or dad. It's not sex specific. Dominant, meaning you can have one non-working copy, and that's enough to put someone at higher risk. And incomplete penetrance, and this is the really important one, that means that of all the people that have that mutation, only a certain amount will ever develop symptoms. Okay, so having the mutation does not mean that you will have aHUS in your lifetime. And this is what we know so far about the penetrance of the different mutations, okay? I would say they're kind of all around 50% for most of them. And again, ignore this last one because we're going to talk about that next. That's completely different. And so what that means is that if you are found to have a mutation, there's a 50% chance that you will ever have symptoms in your lifetime. So it's a lot of numbers, and I understand that. I'm not a huge number fan myself. So what does this mean for my family? So I'm going to break it down. If I'm thinking about my children or my future children, what does this all mean? It means that it's hard to talk about testing people for these mutations that don't have symptoms. So I think in general, if someone is having symptoms of aHUS, a doctor might request testing to figure out which gene it is, because again, that can help how you're taking care of moving forward. But it means it's harder to think about testing people who do not have symptoms, so healthy children, even healthy adults in your family. Because testing family members, it needs to be done with caution, because again, these mutations, having this does not mean you will ever have symptoms. And so they're predisposing, not causative. And this is different than other hereditary disorders. So for example, like Huntington's, have people heard about Huntington's? Okay, so that's another one that it's hard to think about testing because there's no cure for. But if you have the mutation for Huntington's disease, there is 100% chance, complete chance that you will have symptoms. So that's different than what we're talking about here. It's only 50% chance. And again, this is important. If everyone who will test positive for mutation in factor H, for example, we cannot predict who will have symptoms. So we can't tell you, there's no formula to say, well, if you have X, Y, and Z as well as this mutation, that means you're a little bit more likely. And so we talk about this, what about preconception or prenatal testing? Once the mutation has been identified, it is possible to test for it prenatally. And there are ways to, with pre-implantation genetic diagnosis for pregnancy. It's expensive, but it is possible, but you need to have a known mutation to do that kind of thing. It should always include genetic counseling from a medical genetics professional, either a medical geneticist, a genetic counselor, someone who knows genetics. And this is just an example of what that might look like. So Jane was diagnosed with aHUS. Her doctors do genetic testing. They find a mutation in factor H. She grows up and she wants to have a family. She's at that point and she's starting to think about, what is the chance my child might have this? So she goes to talk to a genetic counselor. And the genetic counselor tells her that there's a 50% chance that your baby might have the same mutation that they found in you, okay? But having that mutation doesn't mean your child will ever have symptoms. And so if we break that down, what we know about that penetrance, there's a half chance, 50%, that you'll pass it on. Then there's another 50% that if they inherit it, they'll have symptoms. And so it's really about 25% chance that if Jane had a baby, her baby would ever have symptoms of aHUS. So then we flip that around and we say that's a 75% chance that the baby would never have symptoms. Okay, so that's how these numbers break down. And it's the same for every child. And then I want to talk about this newer gene, the newest gene, DGKE. And these are passed down in a completely different way. So this is what we call autosomal recessive inheritance. And what that means, how it's different, is to have symptoms, the child needs to have two non-working copies, right? So it doesn't have any working copies of that gene. And so for their parents, what that means is they probably got one non-working copy from each of their parents, and their parents don't have symptoms because they only have one non-working copy. So each of their parents have another copy that's doing the job. So this is a little bit different. And what that means for when we talk about future generations is that when a person has two non-working copies, there's a 100% chance that their child will be a carrier. And then only if their partner is also a carrier will the child ever have symptoms. Okay, so then it starts mattering the genetics of the father or the mother that doesn't have a diagnosis. And that's just done here. So if you want to talk about the chance that your future children have aHUS, so who can you call? And I know a lot of people haven't heard about genetic counseling or genetic counselors, and sometimes it's scary to think about talking to someone in a profession that you're, maybe have only heard of in scary situations. But genetic counselors are really there to help. They're there to give you information so you can make a decision. You'll be advised of your options, but genetic counselors will never make any decisions for you. In fact, I always tell people when I talk about genetic counseling, if your genetic counselor tells you you should do something and it makes you feel uncomfortable, go see a different genetic counselor. Okay? So that's not the right person you should be talking to. And then lastly, I just want to talk about, okay, how is genetic testing done? And I'm sure some people in this audience have been through this process. Usually it's a blood test. So it's pretty easy to do. It's usually 1 or 2 tubes of blood when you do genetic testing. And you might be tested for a single gene, or you could be tested for a panel of genes. And like I said, I think it's a little bit more likely nowadays that you would get panel testing, which means you get tested for all of the genes that we know of that could explain the symptoms that you're having. For a panel test, it's about a 30-day turnaround time to wait for results, which can be frustrating and nerve-wracking. For familial site testing, this is different. So you can do site testing if you know the mutation in the family. So if I know mom has mutation A in factor H, well then I don't need a big test because I know exactly what I need to be tested for, right? We know what it is, and so you can do a much smaller test in those situations. There are always 3 possible results when you do genetic testing. I'm sure everybody could tell me 2 of these results. The first is a positive result. What that means is they read through all of the genes that your doctor ordered for you, and they found a mutation, and they think it's very likely that that's responsible for the symptoms. The second is a negative, meaning that they looked through all of the genes we know of, which certainly is not everything we will ever know, but everything we know of, and they found nothing. That to the best of their ability with testing, your aHUS is not due to a mutation in those genes. It could be a different gene that science hasn't found yet. It could be something else more in the environment. We don't really know at that point. And finally, this last result, which can be really frustrating for families, is sometimes they find things in genetic testing and we just don't know what it means. And it's hard to get that answer when you do genetic testing because what that's going to come back as is we know that there's a change in your DNA. We think it might be related to your symptoms, but we're not 100% sure. And sometimes when you do genetic testing, you can find one of those results. So common questions that I get sometimes about genetic testing, how often do I need to get tested? The answer to that is your DNA is not changing. So if you have testing, for example, for factor H, you never have to have testing for that gene again unless the testing changes. So let's say the first test that was ever done only looked at one part of factor H. Well, in 5 years, if it's looking at more of that gene, then you might want to go back and get more testing. But you never have to be tested for what you were already tested for. That's not going to change. And I always tell people to come back within 1 or 2 years, just because genetic testing does change pretty frequently. And sometimes that can just even be a call. Is there anything new I should be thinking about if you test negative? And someone can just say no, or yes, actually you should come in and let's talk about it. So I think this is a hard question. So should I get testing for a familial mutation? So maybe my sister has it or my brother has it, but I don't have symptoms. And it really depends, okay? And I know, it's hard to be in this gray area, but it's a very personal choice for that person. And it depends because everybody's different. And for some people that would be the right choice. Maybe they can't live not knowing. And other people, it might cause a lot of anxiety for someone who would never have symptoms otherwise, would have never developed aHUS. And so this is where it comes in where, even if it's not with a genetic counselor, although that's preferable, talking to someone about these options, talking about how you would feel for the different test results can be more beneficial than it seems. And I speak that as a patient as well. Sometimes when my doctors or my providers ask me questions, I'm like, don't bother me. I don't really want to talk about it. Just let's do this. But once you start talking about it, sometimes things come out and it changes people's minds about what they would want to do. And so, of course, benefits are knowledge, perhaps some increased screening, especially if you're a woman of childbearing. So if you get pregnant and you have a mutation, we should be aware of that, right? Family planning, so if you're thinking about future generations. Potential downsides could cause anxiety for something that you would have never had symptoms of. And there's a high chance that you would have been perfectly fine. This is another barrier to genetic testing, insurance coverage. And I don't know everyone in here's personal experience with this. I don't do insurance for these genes anymore. I do more cancer genetics. But even in cancer genetics, insurance is a barrier. Even though genetic testing is a lot cheaper now than it was when I started about 10 years ago, it is still very expensive to get these tests done. My feeling on this is that this is also where a genetic counselor might be able to help you out. Genetic counselors are very good at making strong arguments for why someone should have genetic testing. And it might surprise people to know that family planning isn't a strong argument, but changing medical care, that's a really strong argument. And so having a medical provider write a letter if you're having trouble with your insurance, not always, but sometimes can go a long way. I've actually done peer-to-peers with directors of insurance companies arguing for testing for patients. So most genetic counselors feel like that's in our wheelhouse and we take that on for patients. And that is it. I am happy to answer any questions. Any questions that I can't answer, I'm going to give out my email, and my last name is Maga, not Mega, just so in case you try and find me. But hopefully this was helpful for some of you. Any questions? Yeah.
The last thing you were talking about is insurance, and
Yeah.
is it? I have Blue Cross Blue Shield. Do they cover it? Do I have to find a genetic counselor? Do I have to go through my insurance, or do I have to
Yeah.
go through?
So the best way to do it, I'm not sure off the top of my head if that insurance company covers it, but Blue Cross Blue Shield, in my experience, is very open to genetic testing in general. So I think if a good argument was made, they would consider it. Of course, I'm in Illinois, and Blue Cross Blue Shield is different in different states. To find a genetic counselor, and genetic counseling is usually covered by insurance. We're pretty cheap as providers come, so usually it's covered by insurance. And to do that, it's best to talk to like a primary care doctor and ask to be referred to genetic test or genetic counselor. There's probably a few genetic counselors in your area, but it depends where you live. It's important to note that there are different kinds of genetic counselors, so there's 3 main kinds. The first is cancer. That's what I do. That is not what you want. The second is pediatric in general. That's the kind of genetic counselor you want your doctor to refer you to. And the third is prenatal, and those are for young couples who are thinking of families. So that is also a genetic counselor that you could be referred to for genetics. But like I said, family planning isn't as strong an argument, and it's always best to test someone in the family that has symptoms first. So I would go to general genetics and say, I need this test because it's going to change how my doctor takes care of me, and I need someone to help it get covered by insurance. And then for family planning, if you have that mutation, then you can go see a genetic counselor that specializes more in that. That was a very long-winded way to answer your question. Any other questions? Yeah, so, and when you say you're...
Which one would you go to?
General genetics.
General.
And I will say providers mix them up. If you get to any genetic counselor, they will know all of the genetic counselors in the area, and they will get you to the right person. Any other questions?
You must have explained it very clearly.
Oh, I think there might be a question over there.
What's the breakdown by sex and by geographic or by race?
Yeah. That's a really good question, and I couldn't find any information on that, actually. Doesn't mean it's not there, but it might be hard to get that information just based on how rare this is in our population. Because of how the mutations are passed on, I would expect that there's not a difference between sex, since it's not a sex chromosome that we're talking about when it's being passed on. Genetic disorders, you'll often hear of things like Fragile X. There are many genetic disorders that are different between boys and girls. That's always, I shouldn't say always, almost always because it's inherited on the X chromosome, and that is different in boys and girls. This, since it's not on the X chromosome, shouldn't be different between sexes, but to answer about race, I'm not sure. But I will look it up. If anyone has a question that they're just maybe not terribly comfortable sharing and it's more personal, again, send me an email. I'm happy to answer your emails and get you to the right person if I can't answer your question. Because I know just the nature of what we're talking about is very personal. Even in groups like this that are wonderful and bring everybody together.
We're actually going to give you a photocopy of her card. We're going to scan it and send it out along with all the slides.
Yep.
So.
All right.
Thank you very much.
Thank you.
Well done.